As we started 15 minutes behind schedule, we probably skipped the question sections, and I asked all speakers to be available during break if there are burning questions. So we arrive at the last speaker, and I'm glad to announce Dr. Abdelaziz Al-Melisi for the last presentation. Dr. Abdulaziz is an assistant professor of emergency medicine at King Saud University College of Medicine, and his academic interests include cardiac arrest, critical care, mechanical circulatory support, and the utilization of telemedicine in acute resus. And he will talk us about the craching aortic stenosis patient. Wow, what a title.
So I would like to start with thanking the scientific committee for giving me the opportunity to be here with you guys. So why we are talking about the craching aortic stenosis patient, why we're talking about an aortic stenosis in an emergency conference. I think it's a very important topic, especially with our aging patient population now. We start to see those aortic stenosis becoming more prevalent in our EDs and our ICUs. So I think those patients has a different type of physiology that we have all to learn and to know how to deal with them when they come in sick. So I don't have any financial disclosure. Also, I want to disclose I'm not a cardiologist. I'm not a cardiac surgeon. I am an emergency physician. I am a cardiac intensivist. So in simple words, I am a resuscitationist. And I think as all of you guys here, we all are resuscitationists, and I think we have to know what to do when this patient comes rolling into your emergency department. So this is one of the patients that I saw during my training. He's a 75 years old male who has history of high blood pressure, hypertension, dyslipidemic, and aortic stenosis. He was seen at an urgent care clinic where he was found to have lobar pneumonia, was discharged home or prescribed augmentin and azithromycin, and was sent home. However, patient didn't get better. 4 hours later, after he was seen at the urgent care clinic, came into the emergency department complaining of severe crushing chest pain, shortness of breath, and he looked very sick. And this is his vital signs. His chest x-ray upon arrival to the emergency department showed pulmonary edema on top of his pneumonia, and his ECG showed typical signs of LVH and LV strain. We did a bedside echo on him, and we found some evidence of aortic stenosis, and we looked back at his old echo, and we saw that his aortic valve peak velocity is 4 meters per second. That means this patient has severe aortic stenosis. So in this talk, I'm going to focus on resuscitating the patient that has severe or critical aortic stenosis, not mild or moderate aortic stenosis. Those patients don't get usually in trouble in the emergency department until they get to the severe form of this disease. So severe aortic stenosis is, that means that the patient has an aortic valve area less than 1 centimeter. In comparison to the normal diameter, which is 3 centimeters, that's a significant decrease in the outflow. And that, this is the summary of what our patient had. So what happens when you have a severe aortic stenosis? What is the problem with that? It creates a fixed obstruction. So you have an obstruction that you cannot change with medication. So it's a fixed obstruction, which leads to a fixed stroke volume. Also, down the line, it will create a thick, non-compliant muscle and also diastolic dysfunction. So the fixed obstruction, when you have a fixed obstruction, what would that do to your physiology? Your LV will struggle, the LV will struggle to pass that obstruction, and the way to do that is by creating a huge intraventricular pressure. So the pressure inside the ventricles will go up to 200 just to bypass this obstruction. And what that does is that your stroke volume, the patient will have a lower stroke volume than a normal person. as well as since they have an obstruction, they don't have enough pressure and time to get all the stroke volume past the aortic valve. So they will have a little bit more of blood remaining after each systole, so that will create a higher LV in diastolic pressure. And this is going to be important in a second when I talk about coronary perfusion pressure. So this is, in summary, this is the problem with their physiology. They have increase in LV wall tension, increase in LV end diastolic volume, and decrease in stroke volume. And if we go back to our physiology time, Laplace law says that if you have a high tension, the way to overcome the tension is by creating increase in the thickness of the LV wall. So this is what the LV is going to do to that patient to decrease the afterload or the wall stress, is by building more muscle. So now the LV will be very thick and very stiff. And that will make the LV less compliant and very stiff, and will cause them to have diastolic dysfunction. So what does that mean clinically? So if you have a thick, stiff LV wall, that means that the passive flow of blood between the left atrium and the left ventricle is not going to be as smooth as with other normal people. So those patients will depend a lot on their atrial kick. So if their stroke volume, or almost 35 to 40% of their cardiac output, is dependent on their atrial kick. So they need to be in sinus rhythm for their survival. Also, they will be very preload sensitive. With the thick LV wall and the stiff LV walls, they will need more volume and more preload to be able to stretch out the muscle and be able to create that huge intraventricular pressure and be able to eject the blood. So in summary, they need to be in normal sinus rhythm, and they need to have a higher preload than normal patients. And going back to the coronary perfusion now, for the coronary perfusion, as you know, since the left ventricle in general creates a high blood pressure in the wall, they need to have, they only perfuse their wall during diastole. So with those patients, as we mentioned, that left ventricle end diastolic pressure is going to be super high. Left ventricle end diastolic pressure will be high. That means that they need their diastolic blood pressure to be on the higher side to be able to perfuse the thick muscle. I'm sorry, I'm having issues with the clicker here. Okay, so as we said, that they depend a lot on their diastolic blood pressure to be able to perfuse their coronaries. So this is an example of our patient. Usually if they have a severe aortic stenosis, their intraventricular pressure is going to be about 200/25. So their coronary perfusion, and if they have a normal blood pressure, is going to be about 55, which is a little bit less than what we want. But once they drop their blood pressure to 40, to 120/40, is there another clicker that I can use? Or if you can move the slides. Next slide, please. Okay. So if they drop their pressure, their diastolic pressure to 40, that means their coronary perfusion pressure can go down to 15 millimeter mercury. And this is going to create an LV wall ischemia, a global ischemia. Next slide, please. Okay, and also the other thing with the other issue, since they have a very critical stenosis or severe stenosis, they need their time to be able to eject the blood. So they need to be on the bradycardic side. Once they become tachycardic, what will happen? Their stroke volume is going to go down, and they will not be able to perfuse the LV wall. So they need their time to be able to perfuse the thick walls, and also and also to be able to eject the blood through the stenotic valve. Next slide, please. So in summary, our hemodynamics goals for those patients, they have to be, we want them to be bradycardic. Can you click next? So they need, you want the rate to be slow, you want the rhythm to be sinus, and you want their preload to be high and their afterload high. Next. Next, please. Okay. So, and you want them to be slow sinus and have higher SVR. Next, please. So, what's the issue with our patient? Can you click next? Yeah. So, if you look back at their hemodynamics, their diastolic blood pressure is 40. Their O2 sat is down, and also they're tachycardic. And so what does that do to them? So the hypotension and the tachycardia causing decrease in their coronary perfusion pressure, which will cause myocardial ischemia, and which will cause wall motion abnormality and decrease in the contractility, which will decrease the stroke volume, which in turn will make them more hypotensive and more tachycardic, and will decrease the coronary perfusion pressure even more and become more ischemic. So they will be in this loop until they crash. So you need to break this loop. You need to break this cycle. So how can we do that? First of all, you need to raise their systematic vascular resistance. You need to raise their diastolic blood pressure. And the medication that we should use for that is phenylephrine. Phenylephrine is a great medication for those patients because A, it's a pure alpha blocker. So what it does, it just increases your stroke volume without touching the heart rate. Actually, in fact, it might make them a little bit bradycardic because it can cause reflex bradycardia, which is, in those patients, is something that you want them to have. The second thing, you have to check those patients if they would need, if their preload, if they would need more volume during their presentation, when they present to you. Sometimes we might need to put them on esmolol if they're very tachycardic because you want to slow them down to be able to perfuse their LV. You won't be able to perfuse their LV and get them through the cycle if you don't perfuse their muscle, and because they need that. And the last thing also, you want to put the pads on them. You want to make sure they remain in sinus. So if this patient goes into AFib or any kind of supraventricular tachycardia, even for a short period of time, you have to cardiovert them immediately. They cannot tolerate not being in sinus rhythm. Our patient, and also you have to avoid any venodilators or vasodilators. Also do not diurese those patients. If you put them on any of those medications, they might crash. So we can delay those until the patient go through their acute illness. Our patient got worse and became more hypoxic, so we start thinking about intubating the patient. So the induction is going to cause the same issue. So what you want to do is to make sure that you start them on IV fluid. If you decide to intubate those patients, it's going to create what the sepsis created for this patient. So I would put 2 large bore IV, obviously, and start infusing IV fluid under pressure bag. And we can, since you decided to intubate those patients, so you want to have their preload up. And also, if they're in AFib, even if they're on chronic AFib, maybe those patients might need to be cardioverted before you induce them, because the risk of them crashing and having a post-intubation cardiac arrest is way higher than the possible stroke. And also, this is one of the very few patients that you need to put an A-line if you have time to monitor their beat-to-beat blood pressure, and so you can act on them fast. So, and that's it for me. If you have any question, thank you so much.